Good afternoon. I'm Sheila Smith. I'm the nurse educator for mental health and rehab. And today I'm going to be with my partner. Her name is.
Good afternoon. I'm Carolyn Lightfoot. I'm the simulation educator and your CPR instructor.
So today we're here to talk about understanding and caring for veterans with mental illness from a nursing perspective. So there are going to be a lot of things that we're going to discuss in today's session. So we hope that you get out how to recognize and provide safe care for veterans with mental illness. And then we're also going to talk about some common mental illnesses, and we're going to give you an overview and what's that going to look like for you while you're on the floor. And then the last thing we're going to do is we're going to do a scenario, and you're going to help me assess a patient who might have some mental health issues. So my first question to you all today is, what are your concerns when you're assigned a veteran that has a mental health or a mental illness? What are the first things that pop into your mind?
Am I going to be safe?
Are you going to be safe? Okay, that's fair. What else? What are other thoughts?
Is he homicide?
Is he what?
Homicide.
Is he homicidal? Yeah, safety. That's a good concern. Are there any other concerns?
Am I trained adequately enough to meet the care needs of this veteran?
Absolutely. Do I have enough knowledge to know what I need to know to care for this veteran? So all of these are fair concerns about when you're working with a mentally ill person. So we're going to talk about some of the things you can and cannot do when you work with those patients. But I first thought I would share with you a few statistics. Do you realize 1 in 5 American adults experience some form of mental illness? That's a scary thought when you think about it. When you think about it, 1 in 5 people in this room, so statistically speaking, at least one of us have had a mental illness. Do you? Yes, it's everywhere. You know, I always joke about mental illness. It's everywhere. No matter what area of nursing you go to, there will be somebody who has a mental illness. Do you realize 1 in every 20 adults live with a serious mental illness like schizophrenia or bipolar disorder, all of those major mental illnesses? We're not talking about a few people. When you look at the statistics, we're talking over 50 million people have mental illnesses. When you think about that, you go, wow. And those are just the people over the age of 18. Now think about your kids. We haven't even discussed those people. So it's a lot of people that have mental illnesses. So we can run, but guess what? We can't hide because they're everywhere we go. They're in every facet of nursing. So what we know about mental illness is that it's not a one-stop shop. There is no blood test that I can do. There is no x-ray that I can take to say, oh, I know he has schizophrenia or she has bipolar disorder. We know mental illness has a lot of components, a biological, psychological, or environmental component. We know that mental illnesses tend to run in families. We know that if you had a mom who had bipolar disorder and a dad who had schizophrenia, the production of an offspring, they're more apt to have a mental illness. We know mental illness is attributed to neurochemicals in your brain. Norepinephrine, dopamine, serotonin, when there's an imbalance in any of those neurochemicals. We know that when you've been exposed to a traumatic event, you're more likely to have a mental illness. Think about our veterans. Think about traumatic events. Imagine watching somebody being mangled on the side of the road. You cannot unsee that image in your head. So there are lots of factors as to why people develop a mental illness. So the assessment begins the moment you walk in the door. The moment you're able to see that patient, you're gathering data. So the first thing you're going to notice is his affect. What does his nonverbal say to you? Does it say I'm sad? Does it say I'm anxious? Does it say, oh, something's going on? Am I nervous? So you want to pay attention to that. I oftentimes tell people that these are clues. These are clues. This is insight into the patient's behavior. You want to look at his environment. Have you ever walked into a patient's room and it looks like a tornado has been through the room? Stuff everywhere, stuff on the bedside table, stuff in the bed. I mean, it's just a lot of stuff. pay attention to that. What clue is this patient telling you? You want to look at his behaviors. You want to look at what he's not saying or doing. Maybe he's looking away. Maybe his eyes are looking suspicious. Maybe he's attending to voices in his head. You know, these are all the things that you need to pay attention to. Appetite and sleep are big indicators for us in mental health. Oftentimes our people with mental illness, they either eat everything on the plate or they eat nothing at all. Because if they're eating nothing at all, oftentimes they're thinking, what did you put in my food? I'm not going to eat that food because, you know, I feel a certain way once I eat that food, or I might believe that you're poisoning me. So you want to pay attention to that. You want to pay attention to sleep. Sleep is a big indicator. Think about when you have bipolar disorder and you're manic. You have what we call inexhaustible energy. You're going to be up for 2, 3, 4, 5 days in a row. Just know the crash is coming. That eventually he's going to fall out, but it may take him 3, 4, 5 days if no intervention occurs. So sleep is a big issue for us. And then you want to assess, particularly for my nursing staff, you want to assess medication. That's the number one thing you can do to help our patients start to turn around. And remember, our medications oftentimes don't instantly happen. It may take them a few days before you start to see any improvement in their behavior. So, how do we even diagnose the mental illness? First of all, like I said, there are no x-rays, there are no lab tests that we can do that tells me, oh, I definitely know you got schizophrenia, or I definitely know you have bipolar disorder. It's based on a history. So the challenge in today's time is that, guess what, we don't see families anymore. You know, the patient comes and the patient comes alone. Because of COVID, we don't get to see families. So I might not even get a good history. I might get the history that the patient's telling me, and I might sense that something is different or off about this presentation, but I don't have any data to support it. We do a full physical exam. Why do we do a full physical exam? We do it because we want to rule out any physical cause for his behavior. You know, when I think about an 85-year-old female who comes to your ER and they have acute confusion, more than likely that's probably not dementia. When you think of that example, more than likely you need to think of something like a UTI. Because dementia, A, doesn't occur overnight. If mama knew who you were yesterday, more than likely she gonna know who you are tomorrow. That's not dementia. Dementia is a chronic, a slow progressive disease. So that's why we do a full physical exam. We also rule out all other medical problems before we rule in the psychiatric diagnosis. And then, of course, we have a psychologist or a psychiatrist that can give us that diagnosis. So, the next things we're going to talk about are the big mental illnesses. And the first one we're going to talk about is good old-fashioned depression. You realize that's the number one illness that we see. Good old-fashioned depression. And depression is not just sadness, because truth be told, we've all been sad at some point in our life. We've all lost a loved one or something that's important to us. We've felt sad. Depression is a pervasive feeling of sadness. It's that pervasive feeling of it's never going to get better. It's never going to be right. It's normal to feel sad after you lose that loved one, but it's not normal, 8 months, 10 months down the road, you're not able to go back to work. You're not able to participate in the things that you used to do. The problem with depression is that some of those patients can feel suicidal. They could feel like I have nothing else to live for. They don't see value in their life, even though the people around them sees value in their life. I might think, oh, this person has a husband, they have children, they have a dog at home, they got sisters and brothers that care about them, but when you talk to the individual, they don't see any of those benefits. They don't see the things that are important to them. All they see is that they're in this hole and they can't seem to get out. And sometimes they may think about taking their life. So you want to be astute to those signs and symptoms, like giving things away that have meaning to them. Or they might say things like, nobody cares about me. My life is not worth it. I don't know why you keep wanting to get me out of this room because, I don't have anything to go home to. They don't see that there is value, there is purpose in their life. The second illness we're talking about is bipolar disorder. Now those are some great people to work with. They have two components to their illness. They can be on the depressive side or they could be on the manic side. And they could swing between the two. Now we hope to have them somewhere in the middle. But when they're on the depressive side, they have all of those signs and symptoms that we talked about. Isolation, being withdrawn, doesn't find purpose and value in their life. But when they're on the manic side, they have what I call the extreme mood swings, the inexhaustible energy. Those are the people who will be up 3 o'clock in the morning scrubbing the walls. Those are the people who would say things like, I need to clean out my closet. And they go to their closet and start pulling out the clothes. And then they think, oh, I need to cook the spaghetti. Then they go downstairs and they go in the kitchen and they start to cook. Then they say, oh, I forgot to go to the store and pick up the cleaning. And then they go to the cleaners to go pick up and see how they go from task to task to task. But guess what? They get nothing accomplished.
I think that's me.
Oh, you think that's your? Well, we might have some of those tendencies. So those are the things that they will do. These are the people who lack insight. This is the person who would go out and buy a Lamborghini when they work at Walmart and make $8 an hour. They have no thought about, no insight about, well, my salary does not reflect the Lamborghini car that I'm purchasing. So those are the people who would do that. They have problems with focusing. They have problems with completing any activity. So schizophrenia. Now schizophrenia, of course, is a major mental illness, and it's a thinking or a thought disorder. You must have the presence of hallucinations or delusions. Now, a hallucination. Tell me, what is a hallucination, people?
You think it's there, but it's really not there.
Okay, so you're thinking you see something that's not really there.
Like
What
pink
is?
elephants and blue monkeys.
Okay, pink elephants and blue monkeys. That is a hallucination. A hallucination will always involve one of the five senses. So think, hearing, seeing, touching, feeling. You know, don't you hear those children outside? I know y'all hear those children. VA got a policy about these children. Why these children are playing outside? Y'all need to talk to somebody about that. Or it might be, you hear that? That's gas coming into the room. You smell it. I know you smell it. We need to call somebody. We really need to call somebody because this gas is being pumped into the room. It's probably going to blow up. This is not a safe building. You can imagine how disturbing this must be to have some thoughts in your head that is not congruent with reality. And imagine you have two competing interests. You have what's going on in your head and you have what's based in reality. And imagine how the patient is trying to decipher what is based in reality. So they lose touch with reality and it's distressing for them. And sometimes they won't even tell you that they're hearing things or seeing things. So you have to be astute to those kinds of findings. Now, a delusion is a false fixed belief. When you think about a delusion, I could tell you I'm the queen of England. You know, I married Prince Harry yesterday, and we have a beautiful child. And he's going to pick me up tomorrow from this hospital. That is a delusion. I am not married to Prince Harry, neither do we have any children that I'm aware of. But that's a delusion. The problem with hallucinations or delusion is you should buy into them. You need to keep it based in reality. If I told you there were spiders on the wall, you should just politely say to me, Ms. Smith, I don't see any spiders on that wall. But it must be distressing for you to feel like there are some spiders there. And you want to acknowledge them. That's what you do for somebody who has schizophrenia. A lot of these major mental illnesses will not turn around until we get some medications on board. And sometimes that's a challenge to get the medications in. So you have to use whatever resources that are available to you.
Suppose somebody agrees with the hallucination. How does that affect?
Well, then you become embedded into that thought process. Because then it's going to be, Miss Lightfoot told me she saw those spiders on the wall. I don't know why this nurse over here, Crystal, didn't know that there's spiders. Crystal, you just don't want to be bothered with me. Get Miss Lightfoot back in here. see, you've compounded the problem instead of keeping your information based in reality. There were no spiders. The other thing, when people start seeing bugs on the wall, a lot of times is attributed to substance use. So you want to think in the back of your mind, have we done a urine drug screen on this person? Because that's one of the first things. That's why we tell you we rule out all the medical issues before we rule in the psychiatric conditions, because some of those conditions will mimic psychiatric conditions. So when you start hallucinating, you thinking he has a psychotic disorder, when in fact he got a hold of some bad PCP or some bad heroin or some bad other drug. So that's what you want to be astute to. That's what you need to pay attention to. Now, I put this slide up here, and it's all about substances and tobacco use. And I want to focus on tobacco in particular. For our patients, the mentally ill patients, sometimes they use smoking to calm themselves down. If you remember correctly, VA went smoke-free about 2-3 years ago or so. And so no longer can they go outside and smoke. Well, that's distressing for somebody who's used to smoking a pack and a half a day. So our patients are going to get more and more agitated because they're not allowed to smoke. So what I would say to you, the nurses in the room, please advocate for our patients to get Nicorette gum or nicotine patches, whatever smoking cessation product we can give them. Because otherwise that's just going to increase their agitation. And you're going to have a more difficult patient to manage. So I need for you to understand that. So what treatments do we do? And this is just a very brief list of treatments. The thing I want you to know is therapy is not done on the inpatient unit. Neither is ECT. Well, it's done on the inpatient unit, but we don't do it here at VA. So the thing I want you to focus on, the part that you can control, which is medications. So the first thing I would ask of you is to look at their history and see if they've been on any psychiatric drugs. Because what historically is, when a person comes into the acute care units, you all are great at giving them their blood pressure pills, their thyroid medications, their heart pills. But sometimes the mental health medications get omitted. Or maybe you didn't even realize that they were taking a mental health medication because maybe it was an injectable. And they take that shot every 2 weeks or every 3 weeks. So you didn't even have any awareness that there was a mental health medication out there. So I'm going to first tell you to look back at the history to see if there were any medications and if he was actually taking it. It's one thing to be prescribed medications. It's a total other thing to be taking medication. So that's the first thing I'm going to ask you to do, is review that medication list. Now, for the people who are in the acute care floors, we already have a process in place that if a mentally ill person comes to your unit, a consult can be placed, and one of our mental health team members will come over and do an assessment and consult with the hospitalist to make sure the patient gets his or her medication. So hopefully you are seeing that process work for you all. Now, if you're in the ED, you have plenty of medical staff who can reorder medications. That's pretty simple for the ED. The ED also has a team in place already down there, so that if they need a psychiatric evaluation, they have social workers and people in place that can do that evaluation and get the appropriate diagnosis going for that patient.
Is it a certain time frame that evaluation has to occur?
Well, it's dependent on a couple of things. If it's a 1013, yes, you are bound by laws and constraints within a certain period of time. If it's just somebody you suspect that may have some mental health issues and you want him to be evaluated, we usually see that person within 24 hours. Also be aware that there is a psychiatrist on call that the hospitalist can consult with over the phone if there are some concerns that need to be addressed today, right now, in real time. So there is no reason why a person with mental health issues should not have access in our system. Spinal Cord has its own mental health team already embedded. Mental health outpatient, you can always call them if you got any questions. We will see people on a same-day service basis if need be, if it's a walk-in person from outside. We also, have inpatient mental health. So there's a multitude of resources that any staff member can tap into if they need to get a patient seen. So what I really want you to know is identification. Identification is the key. I want you to know when something's wrong. You know when you walk into that room and your instinct says, he's different. Something's different. Whether it's what he's saying or whether he's not saying, you want to pay attention to that. You want to know what resources are available. As I've said to you, we have a numerous amount of resources here at Charlotte Norwood. We got inpatient, we got outpatient, we got mental health embedded through all sorts of services. So we got a lot of resources. You just got to tap into those resources. And then I want you to trust your instinct, because it's your instincts that's going to keep you safe. If you see your patient is agitated when you walk into the room, don't go get in his personal space. You're asking to be hit. I'm going to say to you, use good common sense. Use your PMDB skills. Use the skills of verbal de-escalation. You know when something's wrong. If he is agitated, let him pace. It's all right. He's okay. It'll be all right. You want to try to be the kind of person that can engage the patient. You don't want to make him more afraid of you or suspicious of you. You want to assess what's going on in that room. This brings up the question of restraints. On the floor, for the people who are on the floor, can you put a person in restraints here at Charlotte Norwood?
Yeah.
Yes. Okay, so what are the rules in reference to putting a person in restraints?
Differs depending on the place. It differs depending on which area.
Okay, we're going to say for behavioral reasons only. So let's say your patient is out of control.
Don't you have to have a doctor's order for that?
Yeah, you do. So you must get an order within 1 hour of placing a patient in restraints. He or she immediately becomes a one-to-one. So therefore, the nurse gets the order, they put them in restraints, they put a sitter absolutely in the room. The sitter's responsibility, somebody has to be with that patient 24 hours. If the person got to go to the bathroom, somebody got to relieve that sitter, and they sit in there while the sitter goes to the restroom, while the sitter goes to lunch, whatever the sitter is doing. So let's talk about what the sitter's responsibilities are. The sitter must document every 15 minutes. He or she is documenting the person is breathing, the person is eating, drinking, sleeping, whatever activities the patient is doing. You must, as the sitter, offer the person to be able to go to the bathroom. You got to give him something to drink, something to eat, all the things that you and I need to survive as a human. So that's the sitter's responsibility. Now, nursing staff, your responsibility. Your responsibility is to assess the patient every 2 hours, a minimum. You can assess more, but a minimum of every 2 hours. And the assessment isn't, hey, how you doing? Is he all right in there? The assessment is literally going to the bedside and performing an assessment. You're going to check those restraints, see how tight they are. You're going to look at his hand. Is he getting good circulation? Is he able to move the hand? Is he alert? Is he able to answer your questions? You know, all of that. Vital signs. Now, you don't have to literally do them. You can actually delegate that task to the aide. But as long as somebody is monitoring whether he's breathing, you know, those types of things. And there should be a note reflecting this assessment every 2 hours by the nurse. Now, when you get ready to take the patient out of restraints, how should you do it? Should I just let all four go at one time? Extremities? No, probably not the best idea. For Sheila Smith, I usually start with the non-dominant leg. Let's just say I'm a right-handed person. I take out the left leg first. Before I even begin to take him out of restraints, I'm educating my patient as I go along. Mr. Jones, we're going to get you out of these restraints as soon as possible. You know, we didn't want to put you in restraints, but your behavior was out of control at the moment. I see that you're calming down. We're ready to start taking you out of restraints. We're going to start with the first limb, and usually that's the left limb, the left leg. Let him stretch his leg, see how he does. You'll know the person who still is agitated. Once he go to swing and kick you, you'll get the message. So you want to pay attention there. How does he respond when you take the first limb out? Then eventually you're going to move to the second limb. Eventually you're going to move to the non-dominant hand. Then eventually the last one is the dominant hand. Again, you're talking to him all along the way. That's what this is about. You don't ever want to have to put a person in restraints. Restraint should be a last resort. You should use those PMDD skills initially. Hopefully, the patient will calm down. It's dependent on the approach. It's all about treating that patient like you want to be treated. This patient is really struggling. So he's trying to figure out what's based in reality and what's not. Imagine what struggle he or she is going through.
Ms. Smith, I have a few questions.
Sure.
So, how do you discern which restraints you will use, wrist restraints versus mittens? And let's say if I have mittens on the patient, but they are untied, is that still considered a restraint?
Okay, so the first question, which restraints do I use? It has to do with his or her behavior. If the behavior is dangerous to self or others, and whatever behaviors the patient is demonstrating that could be dangerous to me or you, then we would have to use the leather restraints or the 4-point restraints, whatever you have on your floor. So that's the answer to your first question. Now, a mitten, usually that's a restraint for a non-behavioral purpose. That's usually like a older generation person who's picking at the IV. That is a form of restraint, and you do have to document that as well. Now, they don't have to be a one-on-one to do the mitten restraint, but they do have to be monitored. Now, so your question was, is it a form of restraint if the restraint is not tied? If you're limiting his movement in any way, it is a form of restraint. So that should be the answer. If he is limited in any way, that is a form of restraint. Okay? Are there any other questions? So I want you in the end, I want you to trust your instincts. I want you to trust your instincts to know when something is wrong. Usually people, antennas go up when whatever he said to me was different, or the way he looked at me was different, or his mannerisms were different. So trust your instincts. So, in the end, to make a difference, you got to understand differences. You got to understand that our patients are struggling. They're struggling with their self-worth. They're struggling with, I'm just not good enough and nobody cares about me. Imagine how that struggle will translate into your everyday life. Imagine when you feel like people don't get you. Imagine when you're saying, nobody else hears voices in their head, why must I suffer? That is a struggle. We work with veterans, and some of our veterans have seen horrific things, and they feel like we don't get it. But we have to have an understanding. They don't want to be different. Nobody with a mental illness wants to be different or perceived as different. But they're struggling with how I fit in. What's the best treatment for me? That's what this is about. To make a difference in people's lives, you got to understand that they're struggling and that they are different. So now we're going to move into the scenario part. And I get the pleasure, I'm Nurse Smith, and I'm going in to see Mrs. Jones. And Mrs. Jones is a patient in the ED. And I want you to help me to assess Mrs. Jones and see what's going on. And I'm going to start the conversation off. And then I ask for your help. Knock, knock. Knock, knock. Hey, how you doing? Hey.
Hey.
Miss Jones? I'm Sheila Smith. I'm one of the nurses here. I noticed you keep digging in your bag. What's going on?
I'm looking for something.
You're looking for something. Oh, okay. So you're here in the ED. Can you tell me what made you come here tonight? Okay. All right, Miss Jones. So, audience, where do I go with Miss Jones? What should I have noticed about Miss Jones?
Her affect.
Huh?
Her affect.
Her affect. Okay, so what do you think about her affect?
It's flat.
It's
And,
flat?
She seems to be having what you call thoughts.
Yeah, something's different. Apparently, we already know something's different about her. She's preoccupied with this bag. So the first thing in my mind was what? Safety. What's in this bag? Now, coming in, I don't know if the bag has been searched or not, but I would say to her, Miss Jones, can we take a look at some of the stuff in your bag? I noticed you brought the bag and you keep looking.
It's all my stuff.
It's all your stuff. Okay, so you're here in the ED, and we're gonna make sure you keep your stuff. We're going to just look at it and write it down so you make sure you take it back with you when you leave. Is that okay with you?
You gonna take it?
Oh, no, I'm not gonna take it. Me and another nurse, we're just gonna write a log of what's there and make sure that you get it back before you leave. Is that okay? Miss Jones? Okay, so the next thing I probably should have noticed is she's paying attention to other things other than me. Her focus is somewhere else. So that's a clue. So is she hearing voices, attending to internal stimuli is what we call it. And if so, I can't compete with the voice, can I? I can't make her. I might make this. It seems like you're talking to somebody, Miss Jones. Is there somebody talking to you?
You don't hear?
No, I don't hear. Tell me, what are they saying?
They say you're gonna take my stuff and not give it back.
Okay. Well, Miss Jones, can you put your bag up on the counter for me? All right. Do you mind if I touch your bag? I'm not gonna take it.
No, because last time they took my stuff out and I didn't get it back.
Why don't you put your stuff on the table for me? How about that?
But no, be careful with my Bible.
I promise you, I'll be careful with your Bible, Miss Jones.
I got all my stuff.
Sometimes you got to be a little patient with Miss Jones. You know, sometimes it'll feel like it's time, but it's worth your time to give her a little time. If you bum rush her or if you try to prod her along quickly, sometimes she'll become reactive and you might get hit in the process. So you're watching her. Miss Jones, I noticed you have a knife here. Can I? I'm not gonna take it. I just want to see it. Also, it's a very nice knife. So, you know, VA policy is that veterans are allowed to carry a blade of less than 3 inches. Now, I will tell you, if there's a knife, we will usually secure just the weapon part of what she has in her bag, and then we will secure it, and then we will return it to her upon discharge if she can have it. So I would say to her, after she's, you know, displayed all of her stuff, if this was the only weapon, I would say, Miss Jones, you're allowed to keep your stuff, but this weapon, because you know the facility is a weapons-free facility, me and another nurse will co-sign for your belongings and we'll lock it up, and I'll ensure that if you should go with you, your belongings will come back to you.
All right, you make sure I get that because my daddy gave me that.
Okay, all right. So I would secure the knife. I would take it and, you know, put it in a safe or whatever I have to do until we do the assessment. So what are the other things should I have noticed about Miss Jones? We thought maybe she was hearing some voices.
She seems disengaged. She seems distracted, or like her mind is weary, something is on her mind.
Yeah, so you might want to ask some of those questions.
Racing.
Miss Jones, it feels like it's a lot going on for you. Is there something going on at home?
Yeah, I lost my dad about 3 weeks ago, and then I just lost my brother. Lord, it's just hard. You know, this COVID stuff, you can't talk to nobody, can't see nobody.
I can imagine.
Yeah.
I see you got your Bible.
Yeah, I want to give this to my son.
You want to give it to your son, okay.
Mhm.
Will you be able to do that?
I'm going to be here. Can you give it to me?
Okay.
I
So,
got that.
okay, tell me about that.
She's giving away personal stuff that she's already made aware to you that she don't want you to take it, but now she's willing to give it away to somebody else in the family. That's suicidal ideation.
Absolutely perfect. That's exactly what it was. You know, she wasn't accommodating until she wanted to give away her Bible. She's had a lot of losses. If you listen to what she said, she's had a lot of losses. I should pick up on that. The other question that I should pick up on, I maybe should just ask her, Miss Jones, have you been thinking about wanting to harm yourself or kill yourself?
I've had a thought.
Okay, tell me, what have you thought about?
Well, you know, it's been a hard year. It's just been so many things going on, and I just don't know that I want to be around. I don't know.
Okay, so it sounds like she has had some thoughts. So then at this point, I would maybe need to get some further evaluation by our psychiatrist or our psychology team to determine what's the best course of action for Ms. Jones. And you want to ask those questions. You want to blatantly ask her, have you thought about killing yourself? If so, what is the plan? Because you'll be surprised at what patients will tell you. They'll give you a real detailed plan. I got a whole bottle of pills, they're at home, or I got a gun, I got 6 bullets. You know, whatever their plan is their plan. And you have to take every plan seriously. Even if you don't think, oh, that ain't gonna kill you, 3 Tylenol ain't gonna kill you. If they believe it's gonna kill them, we want to take that seriously. We want to intervene and give this patient some help. That's what this is about. You don't have to know everything about everything, but you got to know when something's wrong. You don't have to know, you don't have to remember schizophrenia, bipolar disorder, all of those disorders that we talked about, but you know when something's wrong. When you know it doesn't feel right. You know that she might be high risk for suicide. I would be remiss if I didn't ask those questions. That's what this is about. It's okay to not know everything about mental illness, but it's not okay not to do something about it. It's not okay not to ask the person. That's what we're talking about here today. To make a difference, you got to understand those people are struggling. They're struggling with their self-worth, their self-esteem. This concludes our program. Are there any questions for myself or Ms. Lightfoot?
Thank you so much.
Thank you.
Thank you.